Hi, everybody. I'm Elizabeth Gerard. A lot of people know me as Zoe. I'm at Northwestern, and I run an adult genetics epilepsy clinic and program there. I want to thank Scott and everybody else for inviting me to the party and letting me bring some other friends who take care of grown-ups to the party. But I will say that I think we feel like we're in our infancy here. We clearly are still learning about how to take care of people with rare epilepsies, rare pediatric onset epilepsies. So what I'm going to talk about today is how do we grow the team of adult providers interested in taking care of rare epilepsies. So this is the premise behind my talk. I don't have to convert anybody here. It seems like everybody agrees that adult trained doctors comfortable with rare pediatric onset epilepsies are not common. And so what I'm going to talk about is some of the ways, not necessarily that we make them comfortable, but that we make them comfortable with being uncomfortable, right? I think that's really important. And so talk a little bit about the framework. So why do we have a dearth of providers who feel like they have some expertise in pediatric onset or rare epilepsies? In neurology training, no matter what field you go into, you have to have a minimum of 3 months of exposure to child neurology. And in a one-year epilepsy fellowship, you have to have a minimum of 1 month of training in pediatric epilepsy. So that's usually enough time to get exposure to Lennox-Gastaut or at least 1 or 2 rare epilepsies. However, that's often in the inpatient setting or the EMU setting. It's not taking care of those people as adults or even taking care of them in the adult clinic or any clinic setting where you're providing continuity of care. Our epilepsy program requirements are relatively vague. There's really no specific attention of taking care of the rare epilepsies, although understanding genetics of epilepsies and seizures broadly is important. And then we have a case log for our fellows that they need to create. Even though the Epilepsy Fellowship was created to be about patient care complementary to our Clinical Neurophysiology Fellowship, our case log and procedure log is all about procedures, not necessarily about the exposure to specific patient types. So why is this difficult? I think this is something I've heard already today, but I think care in general, treatment paradigms, especially in the adult world, but in general in medicine, are about goalposts and reaching an end goal. And so in the Epilepsy Fellowship, a lot of things are kind of created where people are taught, I do this, and then I do this, and then if that doesn't work, I'm moving towards surgery. And a lot of our epilepsy fellowships in the adult world are focused on reaching a surgical goal with the goal of seizure freedom, right? And so that kind of goalpost, somewhat guided by evidence-based medicine, but a lot just by sort of consensus and experience-based, is what gives people, especially young physicians, comfort, knowing I'm going through this, and I'm reaching X, right? Whereas if you're taking care of a condition where nobody's taught you what the natural history is as the adult, you don't have any signposts going forward, and most importantly, you're alone. That can be very isolating. And I still remember it was only 5 years ago that I was sat down by 2 administrators that told me that my care that I provided to patients was too complex and needed to be simpler, more streamlined, more algorithmic. Right? So we don't get a lot of support, those of us in the adult world who want to provide, family-centered, complex care. So I think when things are difficult in medicine, doctors retreat to sort of these misperceptions or dogmas. And so I think a lot of people feel like when they encounter a complex patient, they have nothing new to offer. If they can't eliminate seizures, they can't help. Right? And that everything should have or was already done by the pediatricians. So we have a lot to counteract, but we couldn't be more wrong with those misperceptions right now. I think everything at this meeting is saying what I know to be true, and a lot of my colleagues now know to be true. Like, this is the time to be taking care of rare disease and epilepsy. We're just beginning to understand new diagnostics, new therapeutics, understanding surgery and neurostimulation, and really at an advent where we have a lot of clinical trials and new therapies. So there's a lot to get people excited about, but they have to have the exposure to get excited. So basically what I'm going to try to frame is, who do we need to teach? What do we need to teach, which was really covered by a lot of other people today, and how should we teach it? So I think there's a lot of people we need to teach. I mean, the short answer is anybody who will listen, right? I'm going to focus today on those in clinical care world. I'm an educator. I run the Epilepsy Fellowship. So how, really, how do we think about exposing people more to the world of rare epilepsies in adults? But we also need your help convincing and encouraging collaborating physicians, as you'll hear about from Dr. King, and especially administrators and policymakers to support this important work. So, where do we get lost? I think the epidemiological work and the using our notes is great, and I'm here to learn from PERC and what we're doing. But I think I can see in myself and others who take care of this population that we have a syndrome known as fear of not being a pediatric neurologist, right? So when I meet a new patient and I try to correctly describe their syndrome, I have this voice in the back of my head and saying, oh my gosh, what if one of my mentors sees this and I coded it wrong, right? And the ILE has given us this term, DEE. So if I put DEE down, I won't be wrong, right? So I think we both under and overdiagnose. We under-recognize and overdiagnose LGS in our notes, unfortunately, because we don't have the right tools to do it. And then I've seen in colleagues that a lot of patients started getting labeled Lennox-Gastaut when Epidiolex was indicated for that. So then any patient who has ID and seizures gets labeled LGS. So if we want to do medical research based on our coding, we're going to have to get a lot better at coding. So I stole this from your website. It's a beautifully simple picture, and I'm certainly going to work through that with some of my fellows going forward. And I think that's useful, but I'll show you where I still get stuck in a case. So what do we teach people? So this algorithm was put up a couple times. It's beautiful. I'll definitely be using this. But I think even if you can memorize an algorithm as a learner, that doesn't mean you have experience prescribing the drugs. And so my adult fellows are comfortable prescribing valproic acid, lamotrigine, maybe the two of them together, but they rarely get that exposure, topiramate, and cannabidiol and clobazam are having a moment, so they are also seeing those in their patients. But the other drugs, which are very important in the armamentarium for LGS and other DEEs, are rarely ever prescribed by an adult neurologist. And so they can encounter, I first learned them as patients I inherited on these drugs and had to learn about them, the interactions and the side effects from my patients and from reading. So another thing that's really important to teach our fellows is personalized seizure action plans. This does not come up that much in the adult world. There's a really nice simple form from the Epilepsy Foundation, which for a patient with one seizure type and one rescue plan is great, but it's not very helpful if you have a patient with multiple seizure types and very nuanced rescue plans. So I saw that you have some great resources on your website that led back to the seizureactionplans.org by the Epilepsy Alliance. I just got this from a patient and her mother. I thought it was brilliant. But I used to write these from scratch, right? Like I had a template, like a Word document that I would do very, individualized plans, because you need to know what seizures progress to status in this patient, which seizures respond to a nasal medication, which seizures should we treat different ways, and you have to recognize that the person on the receiving end of this may be somebody at a day program who might be new, an ER doctor who has no idea about this syndrome, and so you have to make it really, really clear, and I find that it's much more useful if I do this with the parent. The other really important part, and I've seen this in a good number of review articles, is that not all status is the same. So adult neurology residents get the algorithm for convulsive status epilepticus drilled into their heads. So they know how to treat convulsive status, which is a quick procession of 2 medications and then intubation, right? We also recognize that there's some uncertainty when it comes to non-convulsive status in acute brain injury, which is subtle. We need EEG, and we know that we don't really know what we're doing, but at least we kind of are moving forward. We have some data on how much this injures the brain, right? But when an adult provider encounters non-convulsive status in DEE or Lennox-Gastaut, they don't know what to do. And if they have no baseline EEG, it all looks like status to them, right? And so we've had a case not too long ago that I was presented by my fellows where a patient came in with worsened seizures, was given lorazepam, was put to sleep, and started having a bunch of tonic seizures. That was labeled status, and the ICU promptly intubated the patient, right? Because they don't know these terms. So one group I would encourage you to work with, it would be the Neurocritical Care Society and ER medicine doctors to understand that there are nuances in status. So Fabio did a really great job of going over the importance of revisiting diagnostics in adult patients. So I won't go over all of the details, but I will say that you don't want to sit down with your first patient who just transitioned over to the adult care and said, we're going to do everything all over again, right? Not in the first visit, right? You have to be mindful of which tests you do at which point. Having access to a baseline EEG, ideally a video EEG, is so important for the reasons I just outlined, right? An MRI can certainly be important, but if I had to pick one test, which I was asked, and I'm biased because I run this clinic, I would update the genetic testing first, because that can sometimes help you figure out whether, either knowing you do have a monogenic epilepsy or you don't can help which other tests line up in what order. So just to emphasize that this is from the American Society of Genetic Counseling by Lacey Smith, and emphasizing that we are now, current day, quickly progressing towards exome genome as our first test, but many of the adults who I inherit have not had an exome or genome, and even if they have, it is now time to reanalyze that exome or genome, which is the next important step. Okay. So I use this case when I talk about genetic testing in general to talk about a patient of mine who revisiting genetic testing was really important. She's a 35-year-old woman. She had developmental delay. She had epilepsy with multiple seizure types, tonic, atonic, absence, and myoclonic. And she had some genetic testing at the pediatric hospital. And then when I met her, we did a microarray and an epilepsy panel, which were negative. That was all insurance would let me do at the time. And then in 2020, we did an exome, which gave her a diagnosis. She had a pathogenic variant in the X-linked gene NextMIF, which explained lots of her symptoms and also opened our avenues to start thinking with new community groups about which medications might work for her. And so that was very important. Had I done that exome when she was under pediatric care, this gene hadn't been described yet. So we wouldn't have found it at that time. So had she had an exome, I would have needed to reanalyze that to come up with this diagnosis. Now, this was the main point of the slide, but as I was putting this together, I was like, wait a second, multiple seizure types? So did this patient have LGS? And so this is just an illustration of what I don't know and a lot of us don't know. So she had an abnormal EEG at age 5 after having developmental delay, and she was put on valproic acid at that time without having had seizures. And then the seizures were first noted at age 12, but she was on medication before age 12. And her old EEGs and reports are not available. Her EEGs are not important. The reports are available, or no, they're summarized by the pediatric neurologist who called atypical spike wave. And the diagnosis by a pediatric neurologist in an adult center was generalized diffuse epilepsy. So now I look at our recent EMU. This is her tonic seizure. She also has interesting atypical absence seizures with some myoclonic components as well that wake her up from sleep and last for 20 minutes. Again, to an ICU doctor, that's status, right? As I searched through her EEG, I was like, you know what? I think that's GPFA. You guys can tell me later if it's not, because I'm still nervous that I'm wrong. But she had some areas of GPFA. So I did the LGS rest thing that you provided in the document. She would be an 11, which is passable LGS, which is interesting, right? But now she has NextMIF epilepsy. So she's not LGS or not? I think she's both, right? But I think that's important for us to consider as we think about databases and registries. So how do we teach rare disease? So the bottom line is you can never expose a trainee or an adult neurologist existing to all the different rare diseases, right? And they have all these genes and syndromes in our head because when we went to medical school, it was all about memorizing 35 conditions, right? You can't memorize all the rare and genetic epilepsies that are out there anymore. So how do you teach that? You can only teach an approach, in my opinion. So didactics are helpful, but they don't really translate to care. Meetings and engagement in meetings like this are really helpful. But what I think are sort of some of the ways we can do this in education are through case conferences and exposure and modeling. If you have an exposure to one rare epilepsy, that experience can change and shape how you are, right? So in our genetics program since 2017, Gemma and Carville and I have been running a epilepsy genetics conference, which integrates the clinical picture of the patient, the genetic counseling and genetic history, and goes over the genetic tests that we either will order or have ordered. And then that provides us avenues towards research as well as patient feedback and management suggestions. But also importantly, this has a major educational impact on the nurses, the adult epileptologists, my colleagues, and my trainees who attend the conference as well. We've gotten our reviews from this year's conference, which were really positive, showing that people are increasingly ordering and thinking about genetic testing, but also thinking about how this translates to management and care. So I think we've heard some of these paradigms. The things we need to do is really flip the paradigms for doctors taking care of rare epilepsies, right? We have to switch the goal from seizure freedom to the understanding that a goal of seizure control and quality of life is okay for now. Not that we're not hoping to cure this or prevent this disease, but that for the individual patient, if we try to make the goal seizure freedom, we're just going to be shooting ourselves in the foot. We want to move from patient-centered care to family-centered care, right? You're not going to propose a radical treatment change when the patient's mother has got a new job that she's starting, or the father is going to be away for 3 months, right? You have to think about what's going on in the family and what their tolerance is right now for tests or change, right? And then lastly, I think this is really important. We need to teach doctors to be comfortable with not going into the room and having all the answers, right? So it has to be a switch from this physician expertise to this physician partnership. So I want to say that these are my best teachers. I was very privileged to take care of Savannah along with her mom for about only 2 years, but that really shaped my career a lot. And it was I remember the day I walked into the room and I was so intimidated because not only was this something I hadn't seen before, but the mom had a PhD in it, and like I just didn't know what I was going to do. But I think what has changed for me is to understand that every parent has a PhD in their child's epilepsy, right? And you have to respect that, and you have to use that. For the patient that I talked about before who has Lennox-Gastaut epilepsy, mom had lots and lots of logs of all of the meds and how they helped or didn't help, and she wanted to try one again. I was like, your log kind of says it didn't help, and your doctor's note said it didn't help, and this paper on Lennox-Gastaut said it's not going to help. She's like, but I think it helped. You know what? We did it again, and it helped, right? So you have to understand that the parents' instincts are really, really valuable. So, I've been at the same center for 15 years, and I have a lot of longitudinal patients that I take care of. So I can't keep seeing new patients. So how can I do this? And I think what I can do it is with people who help and who grow the team, both locally and then also nationally, right? So these are some of my mentees. So Dr. King was my first fellow who was in clinic with me for 2 years. We saw patients together. You're going to hear from her next. And she's launching our transition program at Northwestern. Dr. Zhang was my most recent clinical fellow. She was with me for 2 years, was interested in women's epilepsy, but on our, she's moving to the Barrow. At our closeout interview, she just told me, after working with you, I think I'm going to take care of the rare epilepsies. And she worked with a family who had CHD2-related epilepsy for 2 years, and I think they've had a major influence on her life, and I think it's been a really good experience. Dr. Tang is a brilliant physician scientist who's been doing research first here at Penn and CDKL5, and now with Dr. Gemma Carville and SCN1A, and he's going to work with me for years, so I hope to indoctrinate in him how to take care of these longitudinal patients. And I couldn't do, and Dr. King and I couldn't do what we do without the help of Jessica Scarpelli, who is our nurse practitioner and has developed an interest in these patients and are helping us because we can only see our patients if we're lucky once a year. So ideally, here's the model. No one of us can do this alone, right? So if one physician can build other physicians and then they can inspire other physicians and scientists to do this, we can go a lot farther. And if we can do that at multiple places, we could really build the team, right, and build a network. So I'm excited to announce that we were recently funded by an AES Infrastructure Award to build a network of adult neurologists interested in genetic epilepsies and rare epilepsies. So these centers will be working with me to build the genetic epilepsy in adults network. I'm here to learn from PERC and from what you guys are doing to see how we can build the proper infrastructure to do this. We're supported by a really great translational team at Chicago. You'll be hearing from Chris McGraw today. Scott Adney's another translational scientist, and Gemma Carville is a translational researcher who's been really key also in my path. So I am at 18 seconds. I think, what do we need to keep doing this? I think it's a lot of what we talked about today. You know, defining those goalposts with guidelines, with biomarkers, with clinical trials is going to be really helpful. My personal passion, and I know, Scott, you said you're going to share your dream. My dream is actually to have, ideally, the opportunity to build fellowships for those adult providers who want to do this, who want to do both either translational work or care. Those of us who probably should have been pediatricians, right, but we ended up in adult neurology, to really foster that and see if we can build programs for them. So thanks, everybody. Okay.
All right, so I'm sitting here on my phone texting with my colleagues saying, this needs to be its own specialty. So when we learn from CF and we learn from congenital heart disease, they're like decades ahead of us, but do we not need to have a subspecialty that is care for adults with DEEs? So what do we do to make that happen?
Yeah.
Just a simple question.
I mean, I think that there's, I think there's a real opportunity, right? I think people are not going into CNP and epilepsy as much. Most of the positions for CNP and epilepsy are funded based on hospital and procedural things, right? So my dream would be to have a fellowship dedicated to a year that would meet the ACGME criteria for an epilepsy fellowship, but would specifically put people in their outpatient clinics with providers who do this, right? And get that exposure. Also, hopefully protect some research time, use existing resources for research. So those fellowships could be funded either by, but they would need their own funding because the hospital wouldn't pay for it, right? So it's a one-year fellow, which is not that much to fund. But my hope is that we could have multiple of the organizations interested in helping with the adult care, kind of co-fund these fellowships that would train people to go into it. If you have a year of that exposure, I think it would be a big difference, right? So we've talked to some foundations about, like, is that something we would fund? So somebody has not just exposure to one disease, because I think, as you said, you can't have centers of excellence for every single genetic epilepsy, but just for rare disease in general. So if we could have that one-year experience, it could be paired with a CNP year, it could be a special, it could be a research and epilepsy year, but I think that we need to invest in building the people who have the approach but want to learn from experience.